Okay, hi everyone. Welcome and thank you for joining us at the World PICU Awareness Week Day for Asia. So today the theme of the year is sepsis, and together with us we have 5 experts from Asia region talking about the guidelines and the challenges that we are facing. So the reason why we are having this, and it's also a directive from the PICS Federation, is to create more awareness for the PICU, because actually not that many people know us, and through this we want to have more interaction, engagement, and to have some sharing about our sepsis treatment in children. I'm Pavan from Singapore. I'm a registered nurse at the KK Women's and Children's Hospital, and together with me we have Dr. Hwa Jim from South Korea. She's a pediatric cardiologist and will be co-hosting this session. So the format for today will be sharing a case study. It's designed to be quite how to say, it's not very detailed, because we want the experts to have their inputs, and really is to be hearing from them rather to be focusing on this case that we are sharing. So our experts will be sharing. We'll keep the questions and answer to the end, and we really want to encourage our participants to engage with us and to share with us your experiences, difficulties. And if you have any questions in between, just shout out in the chat. We'll be monitoring that so that you won't forget any burning questions. I'd like to introduce our speakers. Today we have Dr. Pitan Tan. She's a pediatric intensivist from Children's Hospital of Chongqing, and together with her, we have Mr. Liu Peng. He's a PICU nurse also at the Children's Hospital of Chongqing. And we have Dr. Ronald Lim Chui, practicing at Cebu, Philippines, and Dr. Eva, who is in the Indonesia. Lastly, we have Mr. Lee Wen Chong. He's a respiratory therapist from KK Women's and Children's Hospital. Okay, without further ado, let me share with you the case for today. So this presentation will provide a case study of a 9-year-old girl with T-cell lymphoma who has developed a septic shock while undergoing chemotherapy. Yep, and the patient's diagnosis, trajectory, and the treatment. So there's a 9-year-old girl presenting with a non-resolving cervical lymphadenopathy diagnosed with T-cell lymphoma. So it was confirmed with an excision biopsy and bone marrow aspiration. So she was started on a chemotherapy with this MARSPOR protocol. So then she was discharged home and electively admitted to the oncology ward for 33 days for D33 of this MTX, intramuscular asparaginase, and IV ampicillin. She then developed abdominal pain and worsening transaminitis. So she was referred to the gastro specialist and empirical covered with IV antibiotics. Subsequently, she developed septic shock. She had fluid refractory septic shock, was referred to the PICU, and was started on vasoconstrictors for persistent hypotension with lactic acidosis. So despite all the treatment with noradrenaline, progressively she was hypotensive and required more inotropes. So then we proceeded to intubate her, and this is the post-intubation X-ray, which shows that she has developed ARDS. And then despite maximum dose infusion of the inotropes, she remained profoundly hypotensive, and the decision was made for VA ECMO. And subsequently, the blood cultures returned positive for E. coli. She further developed multi-organ dysfunction syndrome, treated with renal replacement therapy and plasmapheresis, and she was extubated day 7 of PICU stay. Subsequently, she was discharged from the hospital, and the follow-up MRI shows that there's actually reduced in the lymphadenopathy. Okay, so without further ado, can we have Dr. Pitan Tan to share with us the early detection and diagnosis of patients with sepsis? Dr. P, please.
Yeah, thanks, Pepe. Thanks, Hojin. Good evening, everyone. I'm Pitan Tan from Southwest China, Chongqing. I work in an 81-bedded pediatric intensive care unit of a tertiary care teaching hospital. So it is a great honor for me to participate in this panel discussion. So I think the case Pei-Fen had just mentioned is a very typically sepsis, which most of us have met in our PICU. And as we know, sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. It is a worldwide public health problem for its high mortality, morbidity, and financial burden for families and society. So pediatric sepsis and septic shock continue to be an important cause of child mortality. So under these circumstances, accurate diagnoses are very essential to ensure that the correct interventions are administered and subsequently improving outcomes of sepsis. So let's just take a quick review of what Pei-Fen has introduced us about the case. So firstly, I think the characteristics is immunosuppression, because the basic disease is T-cell lymphoma, and followed by the chemical therapy protocol. And then secondly, it's just with a rapid deterioration, because from the beginning symptom, abdominal pain rapidly progressed to persistent hypertension, and then ARDS required ECMO support. So that is what we often face in the clinical work, right? It is just like the dominoes, once when just one falls, just all lose. And certainly due to the existence of immunosuppression of such patients, some opportunistic pathogens are easily transformed into pathogenic bacteria, such as the E. coli in this case, and it is also necessary to be alert to the infection of special pathogens such as fungi, tuberculosis, and so on. So for the early diagnosis and the detection of sepsis, we have to admit that at present we don't have a very ideal and a very good biomarker for pediatric sepsis. But as clinical doctors and researchers, we have never stopped our steps toward it. So I think for the early detection and diagnosis, we can have several methods. Firstly, is about the inflammation factors. Other than the PCG, CRP, I think the cytokines, which is also the characteristics about sepsis, which we can detect in our clinical work. And then there's the MNGS. They can all, both of them can help us in the early stage of diagnosis. And secondly, I think the metabolomics and various biomarker prediction models also play important role in the diagnosis of sepsis. I think from the invasive to non-invasive detection is a future trend, especially in our pediatric patients, because sometimes, it is very hard to get the blood sample. So if we can get some test of such as urine or some other metabolic products and then get some clues, that will be very important. And for the prediction models, I think it is also valuable because it can combine with several important markers of pediatric sepsis and act as 1 + 1, but above 2. So the last but not the least is about the immune subsets and single cell detection. So this is the most accurate, but it takes longer and costs more. At present, it is mainly in the research stage without large scale clinical applications. So for us in our PICU, for those with high risk of sepsis patients, we will detect cytokines and do the blood culture once admitted in our PICU. And for those with ARDS and septic shock patients, we usually will complete the MNGS detection either from bath or blood or both of them. And for children with high risk factors for metabolic diseases and genetic factors, we usually will communicate with parents and suggest metabolic screening and genetic screening in case of some rare diseases. So I think for sepsis detection, we should act promptly because time is life. So at last, that's my share today. Thanks for inviting me to the discussion. I'm a pediatrician in China, but now I'm physically in Singapore. I love Singapore, and we are looking forward to communication, cooperation, and progression with all the PICU colleagues around the world. At last, welcome to China. Welcome to Chongqing. Thank you.
Thank you very much, Tan Tan. It's really it's really mind-opening because you talk about so much variables and the challenges that we have in the diagnosis. Even getting blood is a challenge. What I really like was the part when you think about IEM. Sometimes IEM is being thought of at a later part, and we tend to miss it. So we'll keep the questions for later. Can we have Dr. Ronald to tell us about the treatment of sepsis in a patient in the PICU?
Yes, good evening, everybody. So the topic that was assigned to me was the antimicrobial treatment of patients with sepsis in the ICU. But if we go back to the case that we were presented with, this patient actually is an immunocompromised patient who was scheduled for chemotherapy, and in the days prior to the septic shock, the patient already complained of abdominal pain and was given empiric antibiotics for that. Now, when the patient was admitted in the PICU, the patient was already in shock, meaning the patient was already hypotensive. And in fact, the patient required 3 vasopressors or inotropic support. So for the antibiotic coverage for these patients with septic shock who are immunocompromised, first of all, it is important to determine whether they are they have severe infection without shock or severe infection or sepsis with shock, because the antibiotic management may differ, especially for patients who does not have hypotension. The recommendation actually is broad spectrum monotherapy. But if the patient already presents with shock, then the recommendation is broad spectrum antimicrobial agents, which can be multi-drug treatment, or meaning that a broad spectrum antibiotics plus another antibiotic perhaps to broaden the spectrum and not necessarily to be synergistic. So the recommendation really is to give an additional antibiotics to broaden the spectrum, meaning from gram-negative to gram-positive. Now, for this patient that is immunocompromised, the incidence of multi-drug resistant infection, especially for gram-negative infection, is actually higher. And that is why we may consider another antibiotic that is of the same spectrum. You can actually add either an aminoglycoside to your broad spectrum antibiotics. And also consider antifungal infection or antifungal coverage for this patient, especially if they have a lot of tubes in their body. No? So that's another thing. Now, the patient actually showed signs already of, or markers already of septic shock through the persistent lactic acidosis. And in our country, in the Philippines, although lactic acid determination is still not universal, meaning there are still institutions which don't have lactate levels, but in most of the hospitals or institutions in the cities, they do have a serum lactate level. And we do use serum lactate level to determine, of course, in addition to the clinical manifestation, to determine whether this patient is in shock or not. And we do use the serum lactate level to monitor also the effectiveness of our therapy, no? Especially for fluid therapy. Now, with regards to the diagnosis and use of, the taking up of the blood culture and the administration of the antibiotics, we do not wait for the blood culture, or rather, if there is a delay in the taking of the blood culture, as we said, no, it's difficult sometimes in pediatrics to take the blood specimen for culture. But if the patient is in septic shock, we have to administer the antibiotics within 1 hour. It's different when the patient is in the ward and you actually have time, and the patient is not in shock, and you actually have time to work up this patient. But it should not be delayed for more than 3 hours. Um, with regards perhaps to the duration of antibiotic therapy, it really depends on the site of infection, the clinical response of the patient, and whether you have taken care of your source, no? So you have eliminated the source of infection. So generally for patients with gram-negative infection and uncomplicated, we usually give the antibiotics for 7 to 10 days. But otherwise, in patients with, especially with MRSA or staphylococcal infection, these infections may need a longer days of treatment. Now, perhaps with regards to how we give our antibiotics, we have actually shifted our mode of giving these antibiotics to a more prolonged dosing rather than intermittent bolus dosing. And I think this has made a lot of difference, especially if these patients are given a bolus dose first, and then the prolonged infusion of your maintenance antibiotic is given rather than your bolus treatment. I'll be happy to answer any questions with regards to this patient or antibiotic management. I'll give you back to our moderator.
Thank you, Dr. Ronald. I really, so when you talk about whether it's, being septic already in a ward and the patient being immunocompromised actually make it more challenging to also recognize. I like the fact that you actually mentioned that, lactate is not widely used in all the centers. So this is really the beauty of having all of us coming together to discuss the limitation that we are facing as a region. And the fact that you highlighted the antibiotics to go in within 1 hour compared to other cases is really important, because in our ICU, it's the nurses who are administering this, and we should learn that antibiotic is really important for a septic patient. I do have some questions, but we'll keep it later. Can we have Wen Chong, respiratory therapies, to talk about the mechanical ventilation in septic patient with ARDS? Thank you.
Hello, thank you for having me. Okay, so if the patient is not already intubated and in distress, we put them on some non-invasive ventilation. Typically, we start with CPAP, and if it's insufficient, we'll escalate up to BiPAP up to pressures of about 20/8. And if there's still no clinical improvement, we will definitely consider intubating the patient. So in our ICU, our default mode of ventilation would be pressure control, SIMV with pressure support. So we would titrate our delta pressure, or in other words, the pressure control, to achieve the tidal volume of 6 to 8 mils of kilograms of their predicted body weight. So for PARTS patient, likely their lungs, as their PARTS progress, likely their lungs are going to get more elastic. So we would employ lung protective strategies by allowing permissive hypercapnia with a target pH of more than 7.2. So in other words, we are okay with accepting tidal volumes in 4 to 6 mils per kilogram, because we want to avoid high plateau pressure not more than 28 and or the driving pressure not more than 15. because they are usually associated with poorer outcome. As we accept a lower tidal volume range, we want to consider increasing the respiratory rate for greater carbon dioxide clearance as it increases our minute ventilation. But do take note that as you increase the respiratory rate, the patient may not have enough time to completely exhale. So we may want to decrease the inspiratory time depending on what we see on the ventilator graphics. So in general, patient with PARTS, we would definitely titrate the PEEP to maximize alveolar recruitment. By doing this, we try to achieve better oxygenation and lung compliance, but taking note that there shouldn't be any adverse hemodynamic effects because increasing the PEEP could affect the hemodynamics. And by increasing the PEEP, at the same time, we avoid end expiratory lung collapse. So this will minimize atelectasis trauma. So in our ICU, we also calculate oxygenation index. It's for the stratification of PARTS. This is because depending on the severity of PARTS, there are different SpO2 target that we have. So for mild and moderate PARTS, where the oxygenation index is less than 16, our SpO2 target is 92 to 97%. Whereas if the oxygenation index is more than 16, we classify as severe PARTS and our targets are 88 to 92%. So to guide ventilator management, we do at least daily arterial blood gases, and we have continuous end tidal carbon dioxide monitoring. And we would correlate it with our, we would check with the arterial blood gas carbon dioxide to see if the end tidal is correlating. If it doesn't, we will use it as a trending purposes, because if the end tidal goes up, maybe there's the PARTS is progressing and we may have to modify the ventilation settings to optimize the ventilation. We also do X-ray, chest X-ray, just to check if the lungs are well expanded. If it's not well expanded, we may consider increasing the PEEP. But also most importantly, to check whether the endotracheal tube is at an optimal depth. So as a respiratory therapist, a lot of times we analyze the waveforms of the graphics. So we look for things like whether it's the patient air trapping, and also if there's any patient ventilator asynchronous. So we would try to optimize settings to reduce the occurrence of patient ventilator asynchronous, such as double triggering. There's one example, because they are usually associated with poorer outcome. And if the patient is in sync with the ventilator, it also improves the comfort. So there's a possibility that the patient may require less sedation as they feel more comfortable on the ventilator. So it is important to conduct standardized extubation readiness tests daily to avoid unnecessary prolonged intubation. So if the patient meets the extubation readiness test criteria, we will start spontaneous breathing trial. So we will change the ventilator mode to pressure support ventilation with a pressure support ranging between 6 to 10, depending on the size of an endotracheal tube. So a smaller tube, we will give a higher pressure support. If conventional mechanical ventilation fail to achieve ventilatory and/or oxygenation goals, we may initiate high-frequency oscillatory ventilation as a rescue therapy. Well, there are not many studies that have shown that it has favorable outcome, but we do use it as a salvage, like a last resort. In some patients, they might have severe refractory hypoxemia. So we also consider using inhaled nitric oxide just to see if it helps with improving the oxygenation. Okay, I think I'm about running out of time. So to end it off, if there's inadequate gas exchange despite maximal ventilatory support, perhaps it's time to discuss the initiation of ECMO. Okay.
Thanks, Wen Song. Thank you. Your lung protective strategy actually bring back this very important idea about doing less might be more. So, and also correctly pointed out that actually high frequency doesn't have like much evidence of its effectiveness, and I agree it's a salvaging effort. So moving forward, let us hear from Dr. Eva about the ECMO management of septic patient. Dr. Eva, please.
Hi, thank you. So I'm Eva Marwali. I'm from National Cardiovascular Center Harapan Kita. I work as a pediatric cardiac intensivist in cardiac ICU. And actually our center is the only ECMO center in Indonesia. Okay, thank you for inviting me to this nice sessions this evening. So can I share my screen, because I am doing some slides to make my presentation easier. Okay, thank you. So tonight I have a job to describe about ECMO and sepsis here. Actually, if I want to say the truth, actually Indonesia has no experience for ECMO and sepsis, actually for medical ICU. But we did ECMO in our center for cardiac ICU, especially for patients post-surgery. But this case is a 9-year-old girl with a T-cell lymphoma. I think she got a septic shock and ERDS and should be on ECMO for severe septic shock. And this case looked like a happy ending story, because after the patient should be on ECMO and can be extubated on day 7 and discharged on day 67. Actually, if ECMO itself in my hospital, the patients, maybe it's because of its cardiac patients, it's more severe condition, and then it can be extubated maybe day 21, like it's more longer, and then the hospital stay will be around like 80 or 90 days. And for these cases, maybe I would like to have some discussions. We know that sepsis actually was historically regarded as a contraindication to ECMO for the previous experience, but since 1990s, a number of studies demonstrated that it could be potentially life-saving in neonatal and pediatric septic shock. And recent evidence showed actually good outcome for neonatal sepsis on ECMO, with survival rate of 75 to 80% and 50% for pediatric. But evidence right now for adults is still poor. And actually this number may be coming from experience center. But I don't know about center that actually is not inexperienced. Maybe the survival rate may even less. So the indication of ECMO for in general, we saw that it can be cardiac ECMO or from the lung disease, respiratory failure ECMO. If it's cardiac ECMO, it fell into 2 categories. It can be related to cardiac surgery or unrelated to cardiac surgery. But these cases actually is purely medical cases, or a lymphoma. So it's oncology. This is a oncology, hemato-oncologist cases with a refractory shock, progressive hypotension, rising lactate, and then it's really hard to treat the patient despite giving inotrope, vasopressor, dilators, mechanical ventilation, and should be on ECMO. The other indication of ECMO is actually for broad is respiratory ECMO. So if the patient with PaO2 to FiO2 less than 60 to 80, despite lung protective ventilation, or oxygen index of more than 40. And there is also some score for some center. They use a Murray score of more than 3. And also the CO2, if there is a hypercarbia and the pH less than 7.0 on high ventilator support. This is PIP of more than 40. And also we use, if you use a high IPPV pressure, so more than 25 the mid-airway pressure. And also we also consider ECMO if the patient within the first 7 days, it's not more than that. So the indication of ECMO in pediatric sepsis, actually, it is always the last resort. Because of we try, maybe all the doctors in the world maybe don't want to treat ECMO with sepsis. It's really very, very difficult case. And they try also to do another treatment before ECMO cannulation. So the rapidity of shock progression and psychological decline is more important than absolute amount of inotropic. So if our patient had very bad hypotension, it's very rapid, and maybe we have to think ECMO for the treatment. So in Red Book, yeah, the latest edition, so stated that ECMO should be considered in septic children if the children receiving dose of more than 0.8 to 1 mic per kilo per minute. It means that the inotropic score is more than 80 to 100, despite other appropriate treatment. Yeah, and then there is a continuous of deteriorating rising lactate, acidotic, and worsening hypotension and multi-organ failure. And then the absolute contraindication, we know that if the patient had a lateral chromosome abnormalities and severe neurologic compromise, it is absolute contraindication for ECMO. And for these cases, actually, it's not incurable malignancy. I think the lymphoma, T lymphoma is curable for pediatric cases. So the patient actually had indication for ECMO if the patient had a very good prognosis for the malignancy. And the contraindication, the relative contraindication is the duration of mechanical ventilation more than 40 days if there is an intracranial hemorrhage because of the recent neurologic procedure for the intracranial hemorrhage, and the pre-existing chronic illness with poor prognosis. And what about the contraindication if we talk about patient with malignancy? Actually, the oncology patient have been historically regarded as poor ECMO candidates. But right now it depends on case by case. So we should choose our patient if our patient have very good prognosis in terms of their oncology disease. We should help the patient with ECMO. This is stated in Critical Medicine 2009. Yeah, it go at all. So the type of ECMO for these cases, because there is a shock, yeah, septic shock. So it is, I'm quite agree to have a VA ECMO here. But if the patient is only have a ERDS, so we have to give only VV ECMO for the respiratory support. So how about the cannulations? The cannulation here depends on based on the age of the patients. Here we can see if the patient is neonate. Actually, some of the septic patient, septic neonate, actually a lot of them are septic because of pulmonary disease. That's why they also consider veno-venous ECMO, for neonate, but with one cannula. So that's better because of rapid cannulation, no differential hypoxemia, but there no direct circulatory support and inappropriate in advanced shock. What about infant? For infant, they also propose for suggest for peripheral veno-arterial and at the carotid sites. So because of this rapid cannulation, direct circulatory support, but there is a limitation because of limited flow rate. And for the young adult with septic cardiomyopathy, actually they suggest for peripheral veno-arterial at the femoral sites. But there is a disadvantage here. There is a risk of differential hypoxemia, which is the patient actually had blue desaturation actually in the upper part of the body, and then it will harm also the coronary perfusion. So that's why they also suggest for veno-arterial. So actually requires 3 cannula. It will be another, the third cannula should be the venous return. So it would, the blood should be returned to the venous side. So that's why veno-arterial. This actually actually the indication for patient with an adolescent, adult with severe combined circulatory and respiratory failure, and it corrects differential hypoxemia that I discussed before. Yeah. The proportion of respiratory and circulatory support easily adjusted to meet psychology needs. So we know that actually it can support the circulatory and respiratory for the same time, but we use the gate clamp. The gate clamp have the risk of hemolysis. What about chart? The chart actually the best one is the central cannulation. So atrioaortic. Why? Because we need highest possible flow rates. So no differential hypoxemia with the central cannulation and associated with lower mortality in children. Yeah, but it requires cardiac surgical service, and also there is the risk of mainly astenitis. So the management during ECMO, the goal is to restore organ blood flow and adequate tissue oxygenation while waiting for recovery. Yeah, so without causing damage to the lung and heart. So hemodynamic support adjusts the flow rate of the ECMO, don't increase the inotropic support, and vasopressor are recommended for vasodilatory shock. So we don't have the term of full flow, no, but we have to do goal-directed therapy. So there is to achieve the goal of mean airway pressure, lactate, venous saturation, and then there is no numbers for each patient. It should be tailored for each patient. Sepsis patient may require very high flow rate. It will be more than 150 to 200 ml per kilo per minute. Yeah, because of that, beware of hemolysis. So during the ventilation setting, ventilation setting during the ECMO, we have to reduce to lung protective setting. So we have to make it very minimal, like last rate, it should be 5 to 10, PIP on less than 20, and very low PIP, don't put too much PIP, and low FiO2. Yeah, unless on peripheral ECMO. So because of this is peripheral ECMO, we know that if the lung is bad, we should ventilate the patient because the for coronary oxygenation. Yeah, if there is differential hypoxemia in peripheral cannulation in ECMO, especially for femoral, we should make a conversion of ECMO to central cannulation or VVA ECMO. So the outcome, actually, it has been discussed before in my slides. Actually, neonatal septic shock is very good, 75 to 80%, and the pediatric is 50%. But in Australian report show actually with high flow and central ECMO, it is associated with better outcome. It's nearly 75%. But adults still poor. But one paper showed that actually refractory septic cardiomyopathy, it means that low ejection fraction sepsis in adult may have better outcome. It's 60% if we compare it only 20% without ECMO. Thank you very much. Sorry if it's too long. It's a very long presentation.
Thank you, Eva. That was a nice presentation. Septic shock was thought to be contraindication for ECMO, and now it is thought that VA ECMO may be a salvage therapy for like among selective patients with septic shock with myocardial depression, like Eva said. So like septic shock with septic cardiomyopathy has considerably better outcome than those without septic cardiomyopathy. Is there any other thoughts or comments? Maybe we have to open to the floor later. Okay. Okay, next we'll go to Mr. Liu Peng, and he's going to talk about the nurse management of septic patients on ECMO. Please, over to you.
Thank you. Thank you for the invitation. I will share my screen. Oh, thank you. Thank you for this nice presentation. I know the nursing management is very important, so I can share my experience about the septic shock patient on the ECMO. This is over hospital. We are in the southeast of China. And this is our department. It's a huge department. We have 2 districts, and the overall ECMO center is established from 2008, and then until now we have 46 cases. And 2 cases about the septic shock. One is discharged from hospital, and one is for death. Our team member is composed of a doctor and all nurses, and because of the pediatric ECMO needs the surgical process, so we need certain like hygiene. So this patient was cardiology surgeon. In our department, the respiratory therapy was controlled by our doctor. So this is our department. Next one is nursing management. As to the patient with septic shock, we think that we should focus on 3 parts. One is regular assessment and the infection control, especially this patient with chemotherapy. 3 is complication prevention. As to the patient assessment, which should part of the ECMO is a non-pulseless devices and generate a laminar flow. So besides the heart rate, we should observe the blood pressure. We should observe the presence or absence of a pulse test. The artery blood test mostly delivered by the ECMO. The patient's artery line should look damaged or even flat. Sometimes experience observed to think the artery line is deficiency. But that's no problem. In our center, we maintain the mean artery pressure above 65 millimeters. The third part is the SpO2, for which part we should monitor right hand or left hand. Just like Eva said, in the ECMO center cases, we to avoid the differential hemothermia. So we need to monitor the CO2 on right hand. But in our center, we observe interesting phenomenon. If the patient's infusion line see the right cardiac artery, sometimes the patient's flow generated by heart itself is not enough. In this patient, the oxygen flow will flow to the right hand. So in this situation, the right hand SpO2 will not represent the whole body. So we need to monitor the left hand or lower extremity. Neurologic consideration is very important to this patient because of this patient will have a cold lesion formula, especially the like the ever said with the hemorrhage of the intramural. So we observe the pupils equal round reactive lives. In our center, we will not daily awake about this patient because this patient, if we stop the infusion of the paralyzed or the animals, this patient will awake and this will be dangerous to our ECMO machine. So we not daily awake regularly. Technically, awake ECMO, we don't come under my center. The next part is flow management. Because of the sound variation of ECMO flow and the first period of the large volume, we need to make the flow very balanced. So we should document input and output. Sometimes we can use the ultrasound to evaluate the fluid balance. The lung ultrasound, the cardio ultrasound is very useful. Next one is the diuretic, can maintain the fluid condition. And if the patient fluid management is fast, you will use the CRT, but it's a tough job for nurses. The patient's skin is very important. As a patient, nurses and doctors is carefully to maintain the flow, so they will ignore the change of the condition. So this patient will better usher generate in every part of the patient, such as the knee, the back, or the ear. So we need to form to prevent the fragile ulcer. After the ECMO monitor, we should monitor the blood flow, pressure, such as P-pump, oxygenator, and pulse oxygenator. This is our document chat. After the complication prevention, we have to prevent the bleeding, the thrombotic hemolysis, infection, and the decannulation. Because of the happening inflammation, some patients will bleed through the tube. So we have to create the heparin infusion according to the ABTD, ACT, or TG. Next, we should avoid puncture or injection muscle. Select minimal negative suction when we need suction from the endotracheal. Next, with the formal body. Because of the patient like this, will generate the foam body from the outside or inlet of oxygen regulator or the infusion or perfusion line. So we need to some observation the extremity or the flow daily entire ECMO circuit with flashlight, and sometimes we should disturb perfusion line. Just as I ever said, the septic shock patient needs a large volume or large load. We call the hemolysis. So we need to observe the urine color, the free hemoglobin, and avoid extremely negative pressure. Because of the patient who receive chemotherapy and have a septic shock, so we usually focus on the infection. In literature, we can find that the nosocomial infection rate is very high. The prevention of nosocomial infection remains a primary aspect of daily nursing care. Immune system suppression and invasive procedure make the patient at high risk of infection. So we need daily white blood cards and cell blood culture at each round, the integrity and the timing dressing. What's more, the insertion port of the canal and looking for running, swelling, bleeding, and potential infection. The important part to infection control is hand hygiene and standing nursing interaction. Also, we can treat the patient with the medium flow room or impose entry restriction. What's more, to prevent urinary or central line infection, especially sometimes ventilator-associated pneumonia. And to the ventilator-associated pneumonia, over time, but some researchers, they use the mechanical cleaning method with sterile urine catheter. This is a short video to show how it works. We use a sterile urine catheter to remove the biofilm generated in endotracheal tube to prevent the ventilation-associated pneumonia. And in our research, we found that the VAT system is lower than the control group. This is the new HPV, and we intervention 9-8 curve, and in 20 hours. And this over paper. Last part is to prevent degeneration. We should a complete region of the circuit and check all fixation. Sometimes we need additional fixation to allow the to avoid the stretching along enough length to prevent the decontamination. What's more, family supporting is very important to this patient. We should create a community an excellent nursing model of a combination role. We have a review registration system to this patient, and we have a recording and playing the work of relative calling of care to promote great rehabilitation. That's my share. Thank you for your invitation.
Thank you, Pen. That was a wonderful lecture. That was wonderful discussion. And you cleaned the endotracheal tube with the urine catheter? That's fascinating.
Yes, that's my research.
Oh, could you show us the paper again so that I can, find the paper and read it? Like slide 27.
27?
Yeah, slide 27, the one that you published in PCCM about the cleaning. I find it so amazing. Yeah. Are you able to go back to slide 27? It looks like it's not moving.
Yeah, it's not moving.
Yeah, but that one really caught my attention. It's so innovative. It's I don't know, would you say it's low risk and low cost, but doing its job? Yeah. We are running out of time. We can have one question. I'm checking the chat now. Any questions? There's a comment about the line being choppy and got echo. That's not me, okay? I actually share the link to my colleagues, and yeah, there are many population there. Any comments or questions from the audience? This is your best time to be asking questions to the expert in the region. Maybe I can ask Dr. Ronald about you commented about longer duration of the doses. Does it mean you give over more days, or you slowly infuse the antibiotics over longer hours? Please, if you can answer.
Yes, not longer days, but rather infuse the antibiotics for a longer period of time. So we would recommend that we do not give intermittent boluses, especially for beta-lactams, and that the infusion duration should be at least 1 to 2 hours.
And do you recommend switching lumens? These are some of the things that the oncology might ask our nurses to do. Like if there's a double lumen, then we will have to swap the antibiotics to sort of coat them. Would you recommend that?
Well, it would be better if it's a dedicated line rather than several lumens for just one line.
Okay, thank you. Any comments from our speakers? No? Okay, if not, we will thank all of you for spending time with us, giving us such a fruitful session. And really, I hope that actually the turnout was really good. We had 73, and I hope that this 73 participants actually learn more about sepsis management, the ARDS, and also ECMO and the antibiotic use and management, really for the PICU survivors. If there's no other, there's a question in the chat. If ECMO is offered for cardiac patients, would centers in Asia provide it for a septic patient? From Manal. If ECMO is offered for cardiac, would centers in Asia provide it? In our center we do, but the challenge is that like what Eva said, the outcomes for my center is not that fantastic. And then historically they are not the best candidate, but over time we have become more accepting and giving septic patient a chance on ECMO. But really my centers doesn't have very good outcome. Any other centers can comment about ECMO on septic patient?
Well, I think it depends on the condition of the patient, but we would in Korea. Any other countries?
Maybe like my center, actually this questions is pointed to our center. Maybe if ECMO is offered for cardiac patient, is it also there is an indication for septic patients? In our center, we don't do ECMO for medical patients like sepsis, septic patients. We never do that, actually. And then we don't know yet how is the outcome if we did it for the septic baby or septic kids. So that's why from the literature, it's maybe coming from a very experienced center. So that's why the result is also very good. But we have to learn, because the experienced center has showed us actually it helps.
Well, in the Philippines, they do ECMO in the capital of the Philippines, in Manila, and probably in Quezon City. But where I practice, we don't have an ECMO center actually in Cebu City.
Yeah, so ECMO is a very logistic, expensive therapy. Yeah, so I'm actually at Phuket attending the Asia Pacific ICU pediatric ICU conference, and actually one of the colleague from Indonesia was saying, you know, during COVID they had 35 machines, but they don't have the resources to run it. So really is labor intensive and it's very expensive. Yeah. We have a question from Tian Wen. She was asking if FO fluid overload has been found to be associated with mortality among some patients, and how should the fluid management be like for septic patients after stabilization? Anybody from the panel would like to take this question? Fluid management.
Are we talking about fluid management after resuscitation?
Yeah, after stabilization.
Okay, so we usually follow the Rose principle, meaning that after resuscitation, optimization, when the patient is stabilized, we do tend to decrease the fluid rate, no? And even if there is some perhaps fluid overload, the last phase of Rose is actually evacuation. So we are more careful actually with our fluids, especially if the patient is already stabilized. And yes, I agree. There could be a lot of danger with fluid overload, especially in septic patients. And if you have, I guess you also have dengue in your region, no? So especially in dengue, there's a lot of fluid overload.
Okay.
Sorry, Pepen, I want to add about the ECMO because our center is a ECMO of the Southwest China. So this year we have done about 50, and I remember there's a congenital heart disease neonatal just with TAPVC. So with a very bad heart function, so cannot stop the blood circulation. So we can just from the operation room and at ECMO, and now the baby is 3 years old and is very well recovered well. Yeah. So I think that that just inspires us just in that is our nutrition of our pediatric nutrition. So I think ECMO is sometimes very, very important for our ICU.
Yeah, it's really good to hear, you know, good outcomes coming from this. Actually, it's a very invasive and traumatic therapy to me. Yeah. Maybe last two questions. I would need help with this one. Dear speakers, if we face sepsis patient presented with severe vasoplegic features, can ECMO help us much?
Maybe Eva can comment on it.
I think that's the question for me. Okay, that's good. Okay, thank you, Dr. Fatih. Dr. Fatih is our colleague in Harapan Kita. We are facing a very hard time if the patient is on sepsis. Actually, the patient cannulated for ECMO because of cardiac indication. After that, had sepsis, and that is really hard to manage the hemodynamic for that kind of patients. So based on the literature, actually, septic patient, especially distributed shock, that have a good cardiac function, but very vasodilate, that's the kind of patient is with a very bad prognosis. Because of this kind of patients also need a very high flow. It means that the flow rate should be increased to 150 to 200, I believe, for the children. And then you also need some vasopressors to maintain the blood pressures. That's why I think the answer for your question is, if the patient had a distribution shock, the prognosis is really bad actually. But some patients survive based on some report out there in an experience center, but in our center in Harapan Kita, it's really hard to manage that. Maybe what about Wajin? Have you ever get that kind of patients?
Well, I think the outcome would be very bad. I think you have to do the sternotomy and put the cannulation and do a very high flow ECMO, but I think outcome would be very bad.
Yeah.
We have a final question directed to Mr. Liu Peng about because you talk about the differential hypoxia, right? So there's a question about how much is the difference between the left and the right upper limb in saturation when using a neck ECMO cannula. If Liu Peng can answer. Liu Peng, are you there?
I have a thank you for your question. Just as a slide shows, if the patient surgery is inserted through the neck to the aortic section, the blood flow with the oxygen flow will generated by the ECMO system will into the right hand. In this position, in this situation, if the blood generated by the heart itself is not enough, the flow has an opportunity to the right hand, to the right hand. So the SpO2 in this situation of the right hand will not represent the whole body oxygen rate. So in our center, we will monitor the lower extremity or right hand to monitor the oxygen SpO2.
So if we think that there's differential difference, the right hand will represent the whole body.
No,
left hand?
the blood is through the neck, through the neck. The infusion catheter will into the like the right carotid artery. If the position is very lower, the flow generated by the ECMO system is strong. This location of the oxygen flow will into the right hand. We call anti differential hypothermia. We observed in patient this phenomenon. So in our center, we will monitor the left hand.
So would you say the difference between the left and the right hand really depends on how far in is the cannula and depending on the position of the cannula?
Yes. And the flow and the heart flow or the ECMO flow.
Okay. So that'll be our last question. We'll be closing a session because we have overrun already. I just want to thank everybody for spending your time with us, and also special thanks to the panelists for taking the time to educate us on this very important topic. We hope to see you again next year. With that, I'll end the session. Thank you very much. Have a good night.
Thank you all.